Hi there, it's Archie. I'm back for the ADHD Care podcast. I hope I'll find you well today. Today I'm joined by a special guest who is in studio with me today. I've got Dr. Willmott, who is a senior clinical psychologist working full-time in the NHS and specialises in all things ARFID, which stands for Avoidant Restrictive Food Intake Disorder, which is also part of an eating disorder. So today we are discussing all things ARFID and also the link between ARFID and ADHD. So first of all, let's say welcome to Dr. Willmott.
Hi, Archie. Thanks for having me on the podcast today.
Great to see you again. It's been a long time.
It has been a long time.
And great catching up. And I'm actually getting excited to bring you on to talk about this particular area that I don't think there's so much limelight that's given to this. As I said, we are discussing ARFID and to see if there is any link with ADHD. And also to find out some of the amazing work that you do in a specialist service in the NHS around this topic as well. So, yeah, quite excited about this. What's been your journey? Certainly, and what was it that drew you to want to specialise in ARFID particularly?
I think when I even decided I wanted to be a clinical psychologist, I don't think the diagnosis of ARFID even existed. So ARFID was introduced to our diagnostic manuals in 2013. And so really starting with my journey to becoming a clinical psychologist, I always used to think I wanted to be a teacher. And then I watched a TV programme when I was about 14. And it was called The House of Tiny Tearaways. I don't know if you've ever heard of it.
Yeah, I remember that.
Yeah, but it was a bit like the Big Brother house for families who were struggling with children with difficulties. So it might be kind of emotional behavioural difficulties with sleep, and difficulties with food and eating were often kind of shown as well. And I remember watching one episode where one of the young boys, who's about, 3 or 4, I think, would only eat yogurts. And that really fascinated me. And when I watched that programme, I thought, and I watched The Clinical Psychologist, I thought, that's what I want to do. That's what I want to go and be in life. So then I started my journey to more kind of towards clinical psychology in general. And started after kind of my undergraduate degree in psychology, started working more in neurodevelopmental conditions, which is obviously where we met. So working in kind of CAMS and thinking more about kind of autism and ADHD. And then I got into the training to become a clinical psychologist. And as part of our training, as well as working clinically, we have to do research as well. And I remember in kind of some conversations with staff members, I was thinking about wanting to look into restrictive eating, but not restrictive eating in terms of kind of more of the well-known eating disorder diagnoses like anorexia and bulimia. And they even kind of said, like, I don't really know what you mean by that, because it was the very early days of ARFID. So I trained from 2017 to 2020. So ARFID was a really new diagnosis. So part of my research was looking into psychological interventions for ARFID, or avoidant restrictive food intake disorder, and just sort of seeing what research was out there on this kind of condition and what people were kind of doing psychologically for this condition. And so then following my training, I applied for roles really that were specialising in ARFID, and because not many people have heard of the diagnosis, and certainly not many people have worked in the diagnosis, having done some research in the diagnosis meant that kind of led me more naturally to work in that field, I suppose. So that's my journey to where I am today.
Amazing. For our listeners that may not be quite familiar with ARFID, would you mind just explaining in terms of what it is and certainly how it differs from eating disorders?
Yeah, that's a very good first question. Like, what is ARFID and what do we mean by ARFID? So ARFID stands for Avoidant Restrictive Food Intake Disorder. As I said, that first entered our diagnostic manuals that kind of have the range of clinical conditions and diagnoses for mental health back in 2013. So it's only been around for about 10 or so years now. And so ARFID sits within the feeding and eating disorders category within the Diagnostic and Statistical Manual of Mental Disorders. And it basically refers to a difference in somebody's eating presentation or profile. So we might see people who have diets that are very limited, that can be both in terms of dietary variety. So people might have a very sort of narrow range of foods that they're willing to eat, or it might be in terms of their dietary volume. So they might just not eat enough for their kind of overall energy needs, or it can be both of those things. So a very limited diet in terms of variety and volume. But what separates ARFID from other kind of more well-known and well-established diagnoses is that the limited diet isn't affected by any kind of body image, weight or shape concern. So with ARFID, there are three kind of main things that might be contributing to the kind of differences with eating and to the very limited diet. So one of those things is sensory sensitivities. So people who are maybe particularly sensitive to the taste or texture or smell or appearance of food. Food's a very sensory experience. Also, there are people who experience ARFID who we call it kind of fear of aversive consequences. So they might be extremely worried that something really bad or negative might happen to them following eating. So, for example, that they might choke or vomit. I hear that very kind of often. More rarely, I might hear people saying that they fear being kind of poisoned or contaminated by the food in some way. And the kind of third main kind of presentation is people who have just a lack of interest in eating or food. So like you can just think like the complete opposite of a foodie. So people who just find food a chore, they find it really boring, they just have no interest in food or kind of eating, they have a very low appetite. And ARFID, to kind of meet diagnostic threshold for ARFID, we have to think about certain things. So whether that limited diet in terms of the variety or volume is affecting somebody's weight or growth, whether there's any nutritional insufficiencies, and also whether it's affecting somebody psychologically or socially.
Yeah. As you're talking there, I'm trying to think as a clinician, how do we spot this?
I often think really, it will often come from the person themselves, or often, we're often seeing children and young people, so often the parents saying, my child eats a very limited diet, rather than something that you'll necessarily spot, because, it's not necessarily that people might look a certain way, or I don't know, we don't see our patients or children and young people eating a lot of the time. So I think we might spot it if a child is particularly low in weight, but the thing with ARFID is that we don't require there to be any weight loss necessarily. So lots of people with ARFID are still very typical weight, or they might even be overweight. But we might notice some differences in physical appearance, and might be looking very pale, which might be a sign of a nutritional inadequacy. So you might spot it, but I think generally we should be asking about it. We have to ask a bit more about diet in our mental health assessments, ask about kind of the variety of foods, kind of eating patterns, eating behaviours. So I think we just need to get better at kind of our assessments, being a bit more holistic and thinking about things like diet and asking more direct questions about diet. Otherwise, I think generally we're a bit more alerted to it, because often parents are quite concerned about often their child's kind of food intake.
Given that it's only been around for 10 years now, would you say? And certainly me as a clinician, this is not something I've been aware of. I think when I think about eating disorders, ARFID is not a name that usually comes on my radar. Yeah. What would help me as a clinician to be able to, I don't want to go back to that word spot again, but I think what would help me and guide me to think there might be some screening that might need to be done in terms of ARFID here if I'm with a young person. It doesn't have to be ADHD, and I know with ARFID, this is something that we want to discuss a bit later on as well, that what would guide me to be able to pick it up from a young person that I'm seeing and they're describing these symptoms for me to think we might need to investigate this further.
I suppose a bit like I was saying before, so parents might be really quite concerned about their child's food intake, so they might be mentioning it to you in an assessment or in a meeting with them. Equally, the child may also talk about their food, but generally I think more of the concern comes from parents, and more of the kind of bringing it up as I'm concerned about this tends to come from the parents. I don't know if I quite understand what you mean compared to the previous question. What would you spot
in terms of, like, obviously with for when we think about eating disorders? I think certainly when you associate the fear of the trying to gain weight, or like some of them who intentionally want to throw up, the different types of eating disorders. With ARFID, for me to think, okay, this might be ARFID, particularly, what was it that would usually I need to be listening out for that's been described by the family that I can go, that this might be ARFID, because it's fairly new, and for us clinicians, we're not fully aware of it. Certainly working in neurodevelopmental disorders clinics, and again, we'll come to the overlap with autism in a minute, but I'm just thinking, what would guide clinicians to be able to think, this might be ARFID?
Yeah, I guess if the patient themselves, whether it's child or young person or adult, or kind of parents, family members, are saying that there are some differences with the food intake, I think just further probing and questioning around that. So something that might help you to think about, is this ARFID maybe compared to other eating disorders, would be, so thinking about the range of foods that are accepted and the types of foods that are accepted. So often it's a really restricted range of foods. There's no specific number on the amount of foods kind of in the diagnostic criteria. So we're not looking to see like under 10 foods or anything like that, but you will quite commonly hear that, or I quite commonly hear that in my practice with meeting lots of people with ARFID, that there's very, very few foods. And often there might be a complete exclusion of certain food groups. So just asking a bit more about like the diet, what does it consist of? How varied is it? Are there some food groups that are completely missing? But also thinking about the overall amount of food as well, or maybe like the regularity of eating. So you might find that people have more of a grazing pattern, or I suppose thinking about that diagnostic criteria for ARFID and the kind of patterns that we tend to see. So asking a little bit more about, are there sensory sensitivities, which you might be asking about as part of your broader neurodevelopmental assessments anyway, but are there sensory sensitivities specifically to food and eating? So are they, really, really sensitive to the taste of food or smells, to the point where they might be running out of the room in response to certain foods? Are they really fearful that something's going to happen if they eat a food? And, if the fear was to be like, someone was to talk about their kind of weight-related fears, then you might be thinking about kind of other eating disorder diagnoses. But if the fear is more about kind of, choking, vomiting, you might be thinking a little bit more about ARFID, and equally that kind of lack of interest that I was talking about before. So actually, if you are asking a little bit more about kind of food and eating, and people just say, I'm just not interested, it's a real chore, I find it really boring, I find it difficult to sit through meal times, I'd rather be doing X, Y, or Z than eating, that might be something where it's starting to sound a little bit more like ARFID than kind of other better known or more commonly kind of talked about eating disorders.
Yeah. Can we discuss about the potential links between ADHD and ARFID? So what might individuals with ADHD be more susceptible to developing ARFID?
Yeah, I think part of the difficulty at the moment with ARFID is, like you say, it's not very well known, and the literature is certainly building and growing, but there's still not that much literature on ARFID, especially when you're starting to think about its kind of overlap or comorbidities with other diagnoses. So there's a little bit more on kind of ARFID and autism that's starting to build in the literature, but there's very little on ADHD and ARFID specifically. I think there's honestly about one or two studies that I was able to find when I was researching for this kind of podcast. There's a little bit more, I think, on kind of ADHD and eating disorders in general, but again, maybe a bit more about kind of like anorexia, bulimia, and particularly binge eating. I see a lot more about like ADHD and binge eating in the literature than I see about ADHD and restrictive eating patterns. So I think at the moment, I can't really kind of give you an answer that's really well established in the literature, but kind of thinking about hypotheses as to why people with ADHD may be more susceptible to experiencing eating difficulties such as avoidant restrictive food intake disorder. I really have to just kind of go from my clinical practice and what I hear and think about patients where that kind of diagnoses kind of overlap, or they have both diagnoses. So I think one of the main things that we hear a lot is differences with interoceptive awareness. So those kind of that sense of how our bodies kind of feeling and that reading our kind of body's cues and things. So we might hear differences for our patients. For example, I was working with one young person who broke a finger and they didn't even kind of realise or notice, because just that reading of the pain in their body, or, you know, recognising certain, bodily signs was much harder for them. So I think we hear that quite commonly for patients who have a neurodevelopmental condition, whether it's ADHD or autism, but that they just have these differences in their interoceptive awareness. So I think some people with ADHD possibly have difficulties recognising hunger.
Yep.
And I think sometimes, even if they recognise hunger, sometimes then responding to hunger is more difficult for people with ADHD than for people without ADHD. So I've heard from patients before that, I do actually know that I'm hungry. I can hear my tummy rumbling. I can feel my tummy rumbling. I'm noticing I'm getting a headache, but actually I'm playing, some Xbox game or whatever. And they've just got this really strong ability to kind of ignore that hunger cue. And they're far more interested and entertained by what's kind of happening immediately in front of them. So I think kind of differences in interoceptive awareness is definitely something that might make people with ADHD a bit more susceptible to developing something like ARFID. But also it's difficult to know whether it's also kind of that alongside maybe kind of I'm just not interested in eating over the kind of current activity that I'm in, even if I can feel those hunger cues.
Yeah.
I think sometimes as well with food and eating, for people with ADHD, what I hear from kind of my patients is that often they just find mealtimes really boring. They're a real chore to get through. And you'll hear parents say that they eat so slowly. It seems like such a task, it seems really laborious. It takes such a long time. And so overall, when I was saying that ARFID's it can be about dietary range, but it's also about dietary volume and the overall amount of food. Well, if eating's really boring, often, a child might eat for like 2 minutes and then they'll like be up from the table and be like, I want to go back to that Xbox game that's actually way more interesting and captivating. And so I think that might sometimes contribute to that difficulties in kind of eating enough food, or might see kind of difficulties like, eating really slowly. And some parents say to me, actually, if, they have like a film on in the background or an iPad, that's something that seems to help them because they're almost distracted by that. And it's a bit like that whole phenomenon of when you're at the cinema and you've got a kind of box of popcorn, you don't even realise how quickly you've eaten it.
Yeah, exactly.
Because you've been kind of focusing on the film rather than the food itself. But I think for some people with ADHD, they get more engrossed in the film. So sometimes distraction really helps, but sometimes it really doesn't help because you can get kind of hyper-focused on the film and really engrossed in that. So what a lot of parents of children who have ARFID and ADHD often say to me is that I feel like I'm continuously prompting them, like almost like every bite, every mouthful. So they need a lot of often like kind of parental kind of accommodation and instruction and prompting just to keep them on task.
Yeah.
I think also, we know that for people with ADHD, that's one neurodevelopmental kind of condition, but we know that ADHD often overlaps with kind of other neurodevelopmental conditions. So more people who have ADHD are also like autistic, and whether there's kind of those, whether it's ADHD and autism or ADHD alone, I think we just know that people with neurodevelopmental conditions often have sensory sensitivities and sensory differences. True. So I think that, given that ARFID's got that kind of sensory component to it, where you can be really kind of hyper or hyposensitive to certain taste, textures, smells, I think that could also be a possible reason as to why kind of ADHD may be more likely to, or, people with ADHD might be more susceptible to also having kind of difficulties with food, which may meet diagnostic criteria for avoidant restrictive food intake disorder.
If we look at the stats, so let's talk about autism. So what's the prevalence of individuals that have autism that also have ARFID that you see in your practice?
That's a good question. I was just trying to rack my brains as to what the literature says. But, it's difficult to establish because I think, like I was saying, there's not that much on ARFID in general. So trying to work out the general prevalence of ARFID itself is difficult. In the community, it's about, I think, at the moment, some estimates have been around kind of 2 to 3%. So I suppose like 2 to 3 out of every kind of 100th person in the community. But prevalence rates for ARFID are obviously higher when we see them in kind of clinical settings. So in kind of feeding clinics or eating disorder settings, it's much higher. In terms of my clinical practice, so we recently audited our patient population, and 35% of children and young people who were coming to our clinic, which specialises in ARFID, have diagnoses of autism. And a further, I think it was 40% kind of was suspected to be autistic. So they were kind of either on waiting lists or following our assessment. We sort of thought, actually, there's quite a lot of traits here, or they're flagging on certain screening measures. So that's about kind of 35% of our ARFID population having known diagnoses of autism, but actually it's probably quite a lot higher.
That is a high number. So if I was me, I'll be thinking, should we not be screening ARFID when people are being referred for autism?
I would, I think I would make a case from kind of what I've seen in the literature and from my clinical practice that actually, if we are working in neurodevelopmental services, it's definitely wise to be screening or asking questions about eating and diet as part of our kind of assessments and, holistic assessment. Screening measures for ARFID, are in their infancy and early stages, but they do exist. So you could use a kind of an ARFID screening measure. But I think just the main thing I would say is just absolutely ask about food and eating and diet as part of neurodevelopmental assessments. But equally, I think in eating disorder services, we should be screening for neurodevelopmental conditions as well. I think it's just becoming, even though we might not have excellent statistics on the prevalence of ARFID or the prevalence of autism within ARFID or ADHD within ARFID, I think we know, or it's increasingly kind of discussed and talked about, I think both in the literature and in services and between clinicians and with people with lived experience, that there is an increasing understanding of that kind of overlap between neurodevelopmental conditions and difficulties or differences with food and eating. So I think, it's about both. Wherever you work, I think it's about being, thinking more broadly sometimes.
No, I 100% agree. And that's something that, I can put my hand up, and that's not something that's routinely asked or screened when we are screening for things like autism or ADHD. So particularly for ADHD, that's something that I'll probably take from this conversation, that it's something that I want to be more mindful of, apart from just the screening, even when I'm doing my assessments as well. I want to explore more around the eating side of things, because some individuals with ADHD can have sensory issues as well, as you know.
Exactly.
Yeah. So in terms of what are some of the challenges that clinicians might face in diagnosing ARFID in patients, particularly with the ones with ADHD, and how can they overcome these challenges?
I suppose it's a little bit about kind of what we've been saying, or what you've been saying, that ARFID is just not that well known at the moment. So and unless you've kind of, lots of clinicians haven't even heard of ARFID. So there might be clinicians, I think, it's improving, but there might be clinicians that are working in neurodevelopmental teams who are screening for ADHD or completing ADHD assessments or autism assessments that just haven't heard of ARFID. I think once you've heard of ARFID and you start looking into it, you can look into the diagnostic criteria, you can read lots about it. Then, I think, you can look into this kind of screening measures. Then you might, or speak to other people like myself that work in kind of feeding and eating disorder services. Then you can start to get a sense of kind of the questions that you might want to ask around ARFID, to be thinking about that as like an additional, possibility. So I think at the moment, one of the main challenges is just that lack of awareness and lack of understanding about ARFID. And I think also just one of the challenges is that, we can't be experts of everything, right? So there's a lot to do and cover within ADHD assessments and autism assessments. So there's a lot to already think about and ask about. So I suppose it's just kind of how do we build that into our kind of practices and assessment processes, and do we do a routine screen for everybody that comes to our service, or maybe or do we, if a parent was to bring it up, then maybe do we kind of dig or investigate a little bit further. I think another challenge that people probably have if they're thinking about ARFID and does my patient possibly meet criteria for ARFID as well, or is that something that could be going on for them, I think it's kind of like where to signpost them to. I think that can be really hard at the moment, because you might say, go to a GP just to check out kind of physical health and maybe ask them about ARFID. But the chances are that often at this point in time that GPs might not have heard of it. So I think one of the frustrations we often hear from parents is that, well, I went to my GP, but I was explaining to them what ARFID is. And so just trying to connect people in with the right people or right sources of support at the moment is very difficult for both, I think, patients and parents or family members, loved ones of people with ARFID, and for clinicians themselves, whilst we're in a very new kind of emerging field.
How do you get your referrals in your NHS work? How is it? The parents referring to the GP and then GP referring to you guys? I'm still trying to work out the route, really.
Yeah, I think so. I've worked in various NHS services that specialise in ARFID, so they do exist, but they are a bit few and far between at this point in time. It's definitely something that I think and I very much hope is improving. But it is a bit of a postcode lottery. So I've worked in different services, so both in terms of kind of secondary community care and also tertiary care as well. So depending on the type of provision depends on your kind of referral criteria and where referrals come from and what you're able to kind of accept. So if you're working kind of secondary or community-based care, you might accept referrals from GPs, but often, it's not necessarily that the GP has picked up on it in the consultation. They may have done, but it's probably more likely that parents have gone to the GP saying, oh, my child's got this very limited restricted diet, I'm worried about it, I'm wondering if it could be ARFID, and then the GP making a referral on.
Wow.
Than a GP necessarily just picking that up of their own.
So it's actually up to the parents themselves to be able to, if they are clued on knowing what ARFID is, then approaching the GP.
I imagine that's, if I was to ask the majority of my patients and their parents, I think that's what the majority would say, that they kind of initiated the seeking more support, and they initiated kind of going to the GP and having a chat about the GP with it. Of course, it's not the case for everyone, and referral routes always look different, and sometimes it might be schools that are picking up on restricted limited diets, and they might advise going to the GP. Sometimes it might be other healthcare professionals that are involved with the child or young person, and perhaps CAMHS professionals, and we haven't really talked about adults with ARFID as well, but
True.
More of our literature is focused on children and adolescents with ARFID. But I think as more people are learning about ARFID in the general population, and I do think social media kind of is helping with that. I think, definitely there's maybe more knowledge about ARFID on kind of Instagram and TikTok. I think maybe more older kind of teenagers and adults are maybe recognising, oh, do I have this thing? And then they might prompt kind of, or going to the GP or thinking about, getting some support for it.
If I think about other conditions as well, that were people really didn't know much about them. I think if you think about the wider public, things like ADHD, people have a skewed views about these sort of conditions, and certainly what you said about TikToks and social media is definitely playing a part in kind of raising that awareness. If we can maybe discuss about the strategies that you've found to be more effective for the patients that are dealing with both ADHD and ARFID, what are some of these strategies?
I suppose you're asking very good questions, but ones that are difficult to answer because ARFID can look so different from person to person.
Yeah.
So kind of regardless of whether they have ADHD or not, we need to be thinking about how is the ARFID presenting for them. So is it a very kind of sensory experience? Do they have that lack of interest that I've been talking about? Or do they have this fear that maybe they will choke or vomit? Because you can have, just to say, more than one of those reasons. So you might have a young person, let's say they may have ADHD as well. That's how you kind of ask the question. They've got ARFID and ADHD, but they might have all three of those things going on, contributing to that ARFID presentation, or they might have more predominantly kind of one of those things, so kind of sensory or lack of interest or fear. I think what I commonly see for patients with ARFID and ADHD is, but this is where we need more research, because I'm this is just a hypothesis or what I feel like I'm seeing in practice, but I often see that kind of lack of interest being heightened for patients with ADHD. So they do just find that, maybe they're not recognising their appetite as much, their hunger as much, or as I was saying before, they're just completely able to kind of ignore it. They're very distractible during meals. They need a lot of prompting. So that's the kind of thing I see a lot for patients with ARFID and ADHD. And often quite a lot of that kind of sensory profile as well. So just having kind of very strong food preferences based on whether they're kind of sensory hypo or hypersensitive to certain kind of taste, texture, smells, the appearance of food. So in terms of kind of strategies, sometimes we talk a bit about, I don't know if you've heard of like habit reversal, if you're trying to like kind of break kind of habits that you know, no longer want to engage in. Yeah. But we sometimes talk about habit acquisition. So how can we kind of foster and develop, you know, more kind of regular eating patterns, for example. I think a lot of it is a very kind of problem-solving approach, a very pragmatic approach. So I will often say to parents, because I think there's a lot of guilt with ARFID that, I'm doing the wrong thing, I'm allowing my child to have an iPad. And I just take a very pragmatic approach when dealing with kind of ARFID and ADHD. And I say to parents, is it working? And if they say, yeah, do you know what, actually, we find that if they sit on the sofa, you know, and they've got their favourite, like, you know, TV programme on, they just eat more of their chicken nuggets or whatever. And like, I definitely get more of the food in that way. So I say, well, if it's, I often say to parents, you know, if it ain't broke, don't fix it. If that's working for you, even if it feels unconventional, you feel that you should be doing something else. But actually, if you were to ask them to sit at the dinner table, that's going to be a really boring task for them. They're going to end up eating one chicken nugget. Then, you know, and I'm not saying, you know, never aim for that, or, you know, sometimes, you know, it might be that the family rule is, but on a Sunday, we're all going to sit and eat together if that's something that's important to that family. So I think it's a very kind of pragmatic problem-solving approach. Whereas if the parents were saying to me, actually my child gets really engrossed in the iPad or the TV program and they don't eat anything at all, then you might think about more structured meal times and actually let's kind of focus on the food a little bit more and sit together. So what's going to work for one child with ARFID and one child with ARFID and ADHD is going to be very different from the next. And I think we really have to listen to parents about what's working, what are you doing that seems to help, what are they or you doing that seems to make matters worse. But yeah, it might be about trying to think about, when I was talking about habit acquisition earlier, like kind of, can we develop positive mealtime routines? Can we get things a little bit more structured, certain times? But it might be things like at school, young people saying they don't have enough time to eat. So can we get them a bit of a snack pass where they're allowed to eat in other lessons, or they're allowed to leave the lesson just before lunch a little bit earlier than others to get to the canteen, so they've got a little bit more time. So it's just thinking about how can we make food and eating as easy as possible throughout the day, really. And often it's very, very practical strategies.
For your team, obviously you specialise in this field. If you think about the history, like how, if you was to go back to, you know, I don't know if you factor in how the child's eating pattern habits have been when they were younger, to see how this developed, is that how you kind of build a picture to understand where this comes from? Is it something that just comes on all of a sudden where they didn't have any eating issues before, or how does it work?
Again, I think this is where ARFID's very, very different from one person to the next. What I often see and hear in clinical practice is that the difficulties with food, so kind of a very limited diet, either in terms of range or volume, have, you know, almost always been there. You know, difficulties right from the beginning. Parents were noticing differences at weaning, or when they went to school, they really noticed that they were different to their peers. They were up a lot more from the table, or just were kind of, you know, had stronger preferences than other children. So often I see that it's quite a long-standing pattern that's sometimes stayed quite stable over time, or sometimes has worsened over time. So you sometimes get kind of a picture where perhaps if a child's been unwell, you know, when you're unwell and a food kind of changes in terms of its taste, and then they find it really hard to pick that food up again. So sometimes we hear this has been a really long-standing picture, but it's almost like worsening over time, and they're dropping more foods over time. Or you might hear people say, oh, you know, it kind of goes in cycles, like they will eat one food for a long, long time, and then they get a bit bored of that food, so then they move on to the next food or a few foods. But for some people, ARFID can come on really suddenly. So they might have eaten a wide range of foods and had no kind of particular differences. I mean, everyone's got their preferences, but, you know, generally they might have been eating a sufficient variety, sufficient volume, but something sometimes happens which may trigger, you know, the diet to really change, and for them to kind of then meet criteria for ARFID. So, you know, a good example of that is I've had patients where they've been eating, you know, quite a wide range of foods, but then something might happen, and that's often like a choking incident, often that they personally experience, sometimes that maybe that they observe. So I've had people choke on kind of noodles or spaghetti or something like that. And then they drop all of their foods and they will only go on to really smooth foods. So I've had children on kind of like just Heinz tomato soup or mashed potato, or a patient who was eating kind of 6 very smooth chocolate bars a day. So that's where that, that's not so much of a long-standing pattern. It's been actually a really sudden, rapid onset. And the diet has really, really changed from something that's quite wide in variety to a very, very limited variety, kind of almost overnight.
Yeah. It's you talking there. I'm just thinking, like, in terms of how, if ever the young person grows out of it, how do they, like, if you think about it, some of your patients when they're getting older, would they get comfortable with certain foods that they were really, really kind of resistant to initially? Going into adulthood stage, how does this kind of like how do they progress with ARFID, certainly from being a child to becoming an adult?
Again, I think this is a very difficult one to answer because the diagnosis has only been around since 2013. So, we don't have that many people that, we don't have many longitudinal studies where we've kind of observed actually, children and young people who have ARFID, and then what happens as they kind of get older. And at the moment, the literature and kind of services are far more set up for children and adolescents. So actually, I think we're hearing less from adults with ARFID, and I think there's less in the literature about what ARFID looks like for adults. So it's very difficult to know what that kind of the course of ARFID looks like throughout somebody's lifespan. What we do know is that ARFID can and absolutely does affect some adults. And some of those, it might have developed in adulthood. Like I was saying, it can come on really suddenly overnight, perhaps if they've had something really scary happen to them, like a choking episode. But we don't know for how many it's that sort of presentation and how many that they would have said, do you know what, I think I've always had ARFID. It's been a really long-standing, persistent picture for me. And I think that's the thing. I think it's a really understandable question that lots of our parents ask. You just asked it on the kind of podcast, but lots of parents will say to us, like, what do you think the future holds? Will this always be the way for my child? Or do you think things will improve with age? I mean, generally, if we think about like general childhood kind of fussy eating, we say that tends to get better with kind of age. And there is something called, I don't know if you've heard of it, but like developmental neophobia or food neophobia. And essentially the best way of thinking about that is neophobia is kind of new means no. So anything kind of that's unfamiliar or different to usual is kind of like, oh, no, I absolutely don't want this. And that's a really normal developmental stage that lots of children and young people go through from about 18 months to 6 years old. So generally, food fussiness tends to improve with age, and children might kind of grow out of that neophobic stage and become a bit more kind of confident with trying new foods and branching out their kind of diet. But that's not to say that's the way it goes for all children, especially with ARFID, because ARFID is not fussy eating. ARFID is over and above, normal, typical childhood development and fussy eating. So I think for some young people, it is something that perhaps will persist throughout the kind of life stages, and it's something that needs to be managed, and we need to think about children's kind of physical health needs and their nutritional adequacy. So it might be that they always have a restricted, limited diet, but they might be able to take a multivitamin, which mitigates some of those kind of nutritional risks. But I think it's just really hard to say and predict for each young person, because each young person with ARFID will be different, their future will look different, and we don't know enough from adult literature from adults with ARFID at the moment. I think one thing we do see clinically is that sometimes as children get a little bit older, they might get a little bit more understanding or an appreciation of kind of, I don't know, looking after their bodies, their nutritional needs, as they're able to understand a bit more about kind of food and, why we might benefit from different kind of foods and food groups. And sometimes that kind of social motivational pressure kicks in for children or young people. So they might actually start to say when they kind of go to secondary school, like, actually, I want to go on school trips, or my friends are starting to go, out, after school, and that might involve food or eating. I'd like to go to McDonald's with my friends, for example. So sometimes that kind of social motivation and social element of food might help people to become a little bit more adventurous. And we sometimes hear from, because, we know generally, like, things there tends to be a genetic component to various things. We don't know much about kind of ARFID and its genetic kind of component at the moment, but we know neurodevelopmental conditions often kind of run in families, and so we do sometimes hear from some children, from some parents saying, actually, do you know what, I think I probably had ARFID when I was their age, or I think I still probably have ARFID now. And some of the parents that we meet that kind of identify as possibly having ARFID sometimes say, do you know what really helped me was kind of a partner, and when they were going out for dates and meals and things. So sometimes I just think that social motivation, whether it's friends, whether it's partner, other families, sometimes that can be helpful as we kind of get older.
Coming back to ADHD, I'm just thinking, like, for some patients that are on medication which can suppress appetite anyway, if you are faced with a client that has ARFID and ADHD and you're trying to support them with their eating, but they're on medication, particularly the stimulants, and it's obviously going to impact on your treatment plan, isn't it?
Yeah. So sometimes we maybe actually get referrals from neurodevelopmental services where they say, I've diagnosed this young person with ADHD. We're considering medication. One of the side effects is reduced appetite. And they already don't have a very massive appetite to begin with. They don't tend to eat enough food anyway. What should we do? Do they have ARFID? Should we go ahead with this? So I think those conversations are often really useful, and it is often really useful to have a kind of thorough assessment of, is this ARFID, and how should we kind of then go about managing comorbid ARFID and ADHD, and is there a role for, medication and stimulant medication? So I would never be the person, certainly kind of one, just generally as a psychologist, but also being someone who's practicing in ARFID, not the ADHD world, to make the decisions on that, but to kind of help the thinking around that after an assessment can be, and to have conversations with colleagues where that is their field and domain, can be really helpful. So I would say it's a little bit like that kind of iPad analogy that I mentioned earlier, that sometimes it's going to have its place and be helpful, and sometimes it's probably not going to be helpful. And it's going to be up to kind of the prescribing clinician to decide, do we think this is worth a shot or not? I think there was one study on stimulant medication, which I wish I'd kind of read or looked into further. But that's maybe we could put a link to it or something. Yeah. Generally, I think from memory, it was a study where all the patients with ARFID had ADHD, but they were also in kind of an intensive outpatient day treatment setting. So really quite at the severe end. And I think they were saying that they did find that in general that the stimulants did have a negative effect on kind of appetite. So it further reduced appetite. But it was a very small number of patients, a very kind of severe end, and that's literally one kind of study. I think what I found sometimes is that sometimes you will find that if the child is taking medication for ADHD, it does have the effect where it further suppresses their appetite, and people don't find it helpful. Children don't find it helpful, the parents don't find it helpful, and they get kind of more concerned about that. But actually, interestingly, I would say in my clinical experience, more of the time, if they're prescribed stimulant medication, even though it sometimes has the side effect of reducing appetite, sometimes what it can do is help children sit and attend to meals a little bit more. And so sometimes we find that actually they are more able to eat more. They're more able to stay on task and to focus on eating. So, I'm not here to provide any sort of medical or medication advice in my role, but sometimes I think it's kind of about prescribing, kind of seeing what happens. But I think it's very useful to be monitoring things like, what's your appetite like? Is this affecting your weight and height? What effect is this having? And if there is an ARFID service or an eating disorder service where people are able to kind of consult with, or if there's able to be any kind of additional psychological support around thinking about kind of just the behavioural aspects of food and eating, that can be really useful to kind of work together and when that kind of question about stimulant medication comes up, because I certainly have patients where they're on medication, we won't work with them for the entirety of their time where they're kind of on medication, but where, when they're starting that, or perhaps they've been on it for a little while, where we sort of think about the kind of general strategies that can go alongside that to make sure that they're kind of not having any kind of negative consequence from that, like low appetite. So actually yes, it might increase that low appetite, but what can we do to safeguard that? So actually do we need to make sure that teachers are prompting a little bit more in the school day? Do we need to just try and increase portion sizes so that we get more food in? So just kind of things like that we think, well, what can we do to supplement kind of psychologically alongside perhaps the medication as well, if that is going to have that kind of negative effect on appetite.
From a prescriber's point of view as well, I just wanted to add that there are different types of stimulants. There are some that last for a short period of time. So in some cases where we've had, I've prescribed short-acting, fast-acting release medication stimulants, which only last for 4 hours, which allows the appetite to return, and they'll be able to eat in between taking the first and second dose. There's also option of the non-stimulants as well, which tend not to be significantly impacting on the appetite as the stimulants. But I agree with what you said. I think some of the dietary management around kind of increasing portions, increasing kind of full fat diet sort of things, introducing full fat meals and milks and yogurts and things, which I tend to advise. I think that advice could be used for someone that's got anorexia, for example, because I've had cases where people say to me, can you avoid stimulants completely? Or they've tried non-stimulants, not really having the impact on their symptoms as much. And again, I like the point what you mentioned about cases where, yes, they have an eating issue, but certainly giving them stimulants has allowed them to actually sit down and eat, because they can focus and concentrate.
Yeah, I think just generally, I would just say this is the thing with ARFID. I think the word I feel like I say all the time in my work is like nuance, and it's such a heterogeneous condition in the way that it presents and the way that we need to manage it. So we really have to think about what's going to work for this individual, and we won't always know what's going to work. We don't have a great evidence base that we're sitting on. The evidence base is emerging for our kind of strategies and interventions to support people with ARFID. So a lot of it is a bit trial and error, and sometimes that will be like taking a bit of a risk or seeing what happens and just kind of closely monitoring, so we start this medication, and like you say, like that's where that kind of expertise, that dual expertise comes in, doesn't it? Like you will know more about kind of the different types of medication and when the side effects kind of wear off, and what might be most appropriate to prescribe. If a patient has perhaps ARFID and has a low appetite, maybe you'd be thinking about a certain medication in the first instance, so that it has time to kind of wear off or whatever, so that they can eat dinner when they get home. So I think
and in some cases you can have breaks as well with stimulants, allowing them to eat more, like weekends, school holidays and things like that. So there are ways and means you can manage this.
Yeah, absolutely. We sometimes talk about weekends or school holidays being a buffer for children with ARFID. So where, even if they've not necessarily got ADHD and they're not necessarily on ADHD medication, sometimes, children who have ARFID, especially if they're neurodiverse and they have ADHD or they have autism and school can be quite stressful or difficult, they might just be really anxious in the school environment and find it really hard to eat enough generally. So we sometimes talk about, go for, sometimes breakfast is really, really hard because they're really anxious and worried about the school day, but like go for a bigger dinner, for example, or, make sure that there's a big breakfast at the weekends. So again, it's that really pragmatic, practical approach. And when can we, if children are struggling with low appetite or not eating enough food, where are those buffers in their week? And lots of the things that we've just talked about, and you're talking about so I was talking about increasing portion sizes, or you mentioned kind of full fat options as well. Sometimes these things aren't necessary. It's whether their weight is faltering, or whether they're experiencing weight loss, or they're low in weight or should be at a kind of higher weight, or whether their growth's being affected, or there's nutritional insufficiencies, and that's really important to assess for a child or young person with ARFID, whether they've got ADHD or not, because actually we might not need to advise full fat things if actually they might have ADHD, but they are a really good height and weight, and actually they're not nutritionally inadequate, or perhaps they are, but they're managing it with a multivitamin. So I suppose it's kind of, again, that kind of the advice that we would give would depend on kind of the presentation of ARFID. It would depend on whether there's any comorbid neurodiversity, autism, ADHD, but it would also depend on, is their physical health affected by this? Is their nutrition affected by this? What advice do we need to be providing around kind of the amount of food or the types of food or multivitamins, for example?
Yeah, and I think about, me as a parent as well. I think if I think about one of my children who here, I would describe her as more of a little and often eating patterns. and if you think about it, sometimes we put too much pressure on having to sit down and eat meals, proper meals, and emphasize too much on that. And sometimes some people are not made up in, they don't like sitting down and having a full meal. They might have a little bit of it, but then in an hour later they'll be asking for a snack. And us as parents as well, I think we just have to be more relaxed when it comes to particularly children. The more pressure you put on them, the more unlikely that they will actually want to actually engage and sit down and actually eat.
Yeah, in general, that is our advice. And it's really hard because obviously, feeding your child is one of the most important, if not the most important thing that you do. It's about, at the end of the day, keeping them alive and well and healthy. But generally, if a child's kind of physically okay, so their weight and growth isn't being negatively affected by their diet, or they've not got any significant medical consequences as a result of their diet, and nutritionally they're okay, and that might be even not necessarily that their diet's the best in the world, but they're accepting a multivitamin or something like that. So if they're kind of physically and nutritionally okay, we generally say that actually relaxing a little bit, as hard as that might be, and trying to have the more low pressure approaches, and just think about kind of actually, ideally we'd really like them to sit around the table, but or to have the kind of full meals and 3 full meals a day with some snacks. But actually it might be that a grazing pattern works better for that child. And actually if we can, if parents are kind of able to sort of think this isn't maybe conventional or what I imagined this would, parenting would be like, or feeding my child would be like, but actually it seems to work for her or for them and for us, then that's when I say that pragmatic approach comes in. I think where I would kind of differ with that is that actually sometimes, we really need the parental boundaries as well, or, a bit more of a kind of pressured approach if there are kind of physical, nutritional kind of consequences, then we really might need to kind of be we really need to kind of get this multivitamin in, for example, and we might need a little bit more kind of a direct approach. But generally, they're kind of, I think I was saying this before, but there can be a lot of guilt around, am I doing the right thing? Am I feeding them the right thing? Am I feeding them enough? Or they're not sitting at the table. And I think when you're parenting a child with any differences, whether that's kind of neurodevelopmental differences, whether that's ARFID, often we do need to think a little bit outside the box, and approaches are a bit unconventional or a bit different. And I think I often hear that parents are often quite wound up by often other well-meaning parents saying, oh, well, just give them to me for the weekend. And you're like, if it was that easy, I think I'd have tried that and I'd have done that already. But I think, a lot of the approaches and strategies generally are things that are kind of, perhaps we didn't expect. And I think this is what I find so interesting about food and eating, because there's a really big cultural component to food and eating as well, and we'll have all had experiences of growing up and being parented and being fed ourselves and certain messages around food and cultural expectations around food, maybe both in terms of religion or certain kind of backgrounds, but also just in terms of the time that we're living in as well. So one of the things I often say to parents as well, or I often kind of just think about, is what have our expectations on children's diets or our diets kind of have become or evolved over time. So if you think about kind of, the standard diets in the 1950s, 60s, 70s, even maybe 80s and 90s, there just wasn't as much kind of cultural influence on our food. There wasn't as much choice and variety. Yeah. So now I kind of, I sometimes think, oh, well, if, back in the, 1960s, if a child ate cornflakes every day with milk, would people be so worried about that as perhaps they are now, because there's such a huge variety of foods available. So, I think just thinking about ARFID as well, I just thinking about kind of cultural background, our families of origin, the times that we're growing up in, and how that might affect our kind of beliefs about how broad children's diet should be. Because actually it's not that unexpected that children's diets are a little bit more beige and bland, and our kind of taste buds develop over time. But that's not me I hope that doesn't sound invalidating to parents who are listening, where there is ARFID, absolutely there's kind of a really strong dietary restriction, but it's just something that I get very interested in at times.
Yeah. You touched on research earlier, that it's still in its infancy. What are things as far as research is concerned with ARFID? Not necessarily the link with ARFID and ADHD, because again that's further down the line anyway, and I can see that evolving, certainly the overlap with autism and ADHD and all the other neurodiverse conditions, but certainly just ARFID on its own, the research behind it. Is there anything that's ongoing currently? Are you doing a research in your kind of special clinic?
I suppose there are, like you said, so the research for ARFID is in its infancy for sure. I think there is growing research about kind of the prevalence of ARFID and the presentation of ARFID. I think what's definitely missing at the moment is studies on ARFID that, like I was saying before, that are longitudinal, studies in ARFID that are from kind of different cultures and backgrounds. So we know the research currently is dominated by white Western samples, as a lot of mental health research is, but that's the case for ARFID at the moment. And a lot of research is focused on child and adolescent populations with ARFID. So we definitely need more research into kind of adults with ARFID as well. I think there are increasing studies reporting on kind of interventions for ARFID. So what can we do? What treatments have been applied? So often for younger patients, behavioural interventions are reported. Some kind of group programs or more parent-focused programs have been kind of developed or evaluated. I think also CBT is emerging for ARFID as well, for kind of older children, adolescents and adults. So really kind of often I think for tackling that kind of, especially if there's like that fear that's driving ARFID, so kind of choking phobias, then something like CBT might be appropriate. And there have been some studies on kind of family-based treatments and family interventions for ARFID as well. But generally the treatments or interventions for ARFID and studies on that are really, really broad. They're really varied. Some are, delivered virtually. Some are these intensive inpatient programs or intensive behavioural programs where a therapist is going into somebody's house daily or multiple, 3 times a day across all the meal times. Those are often ones kind of in America. So, we're definitely building the literature on kind of treatment options and or kind of treatments that are emerging or intervention packages that are emerging. So that's kind of growing. I think there's definitely increasing literature on the ARFID and autism and thinking about the kind of overlap between those two conditions, but I think very, very little on ARFID and ADHD at the moment. I think you asked me about any current research that I'm involved in, and neurodiversity and ARFID is definitely my kind of special area of interest. So at the moment in my service, so in the service that I work in, everybody who comes to us is screened for autism using a 10-item questionnaire called the AQ10. So we're currently looking at how useful is that in our patient population. Do we think that's kind of picking up? So we're kind of looking at it. If you already have a diagnosis of autism, is that kind of flagging on the questionnaire, or is that helping us to identify those that we suspect might be autistic? So we're just kind of looking at how useful is that questionnaire in our population of patients who have ARFID at kind of screening and picking up possible neurodiversity or specifically autism. So I would like to in future maybe think about that for ADHD as well. Should we start screening for ADHD? And thinking, even to be able to start to better understand the prevalence of ADHD and ARFID as well, and the kind of the comorbidity between those conditions, we really need to be kind of screening for these things and making a note of when people meet that diagnostic, they come to us with that diagnosis. So that's a little bit of kind of research I'm involved in. And also, I'll leave it there.
Okay. What advice would you give to healthcare professionals who are trying to navigate the complexities of treating patients with ARFID? And certainly if we add ADHD into the mix as well. I know what you're going to say. It's still in its infancy, but certainly going forward, what would you advise? So certainly for me, I'm dealing with ADHD. What advice would you give me? Certainly,
if you were dealing with ADHD and a patient that you thought had ARFID, I think maybe like I was saying a bit earlier on, is definitely just trying to ask more questions about the diet. Asking about dietary variety, asking about dietary volume, asking about mealtime behaviours, maybe doing a screen for ARFID. There are some kind of screening measures out there, which maybe, again, we can signpost people to. But also I think it's thinking about, I often think of ARFID in kind of a bit of a 3-tiered way. So thinking about kind of physical risk or physical health, nutritional risk, and then the kind of psychosocial aspects as well. So I don't know, because I'm not working in neurodevelopmental services, what sort of physical things you might be considering. But, maybe just thinking about the child's weight and growth. Are they tracking their centiles? Are they falling off their centiles? Have they lost weight recently? Do they seem to have any kind of complications or consequences from their limited diet? So are they like severely constipated, for example? Have they seen anyone, like spoken to anyone? Have they gone to the GP about their physical health, or a dietitian if they're worried about the kind of nutritional adequacy? Even just things like, do they take a multivitamin? You might not necessarily be there to be advising, oh yeah, that's the most appropriate one, for example, but it might just give you a bit of an indication of, I don't know, are they, is their diet that limited that the parents thought, I don't know, that they need to take a multivitamin, or, maybe just that the parents aren't necessarily worried, but they're taking a multivitamin, and that might give them a little bit of a safeguard and reassure you a little bit. But so I would maybe think about, the questions that touch on kind of physical, and think about physical health, things that think about nutritional health, and I think also then that psychosocial impact. So, for you as a clinician, if, I suppose you're thinking about their ADHD and how that might affect them in their day-to-day lives, but does their food intake specifically seem to be also having an impact on their day-to-day lives? So, are they reluctant to go to school because, I don't know, they don't take in a packed lunch, and the school meal, they really don't like the school meals, school hall's really stressful, or they just want to go outside and play with their friends rather than sit and eat. So, are they worried to go to parties or social events because of their food and eating? So those would be things that I'd be kind of maybe thinking about as well.
Yeah, sometimes there could be an underlying medical issue that they have that can impact on their eating as well.
Absolutely, and I think that's sometimes when we absolutely need to refer to people, go back to GPs or paediatricians, because we would not want to be thinking about ARFID or diagnosing ARFID if we actually think that there's, I don't know, sometimes we discover that children have celiac disease, for example, and there's a medical reason as to why their food, they're really struggling with their food intake, or seem to have a very difficult relationship with food, and it's actually because they're in pain a lot of the time, or they're feeling really unwell, or they have this medical. So it is really important that you might have some things that are said to you in the assessment, or that you ask a little bit about diet and you're thinking, oh, is this ARFID? But that's why often the first port of call would be someone like a GP or a paediatrician who could actually sort of maybe do a blood test and screen for some of those things to just rule out or check whether it's something medical causing the restricted or limited diet.
Are there any resources or support networks that you can recommend for individuals and families dealing with the complexity of ARFID?
Yes. So, I would say that the BEAT website and organisation, so BEAT is an eating disorders charity, that has some really good information on ARFID, and also they run some workshops for parents whose children have ARFID, and sometimes I think my understanding is that they don't need a formal diagnosis, so just thinking about how to kind of support carers in supporting children and young people with ARFID. So BEAT have some kind of workshops, they have lots of really good information, and I think they're developing their kind of workshops as well, so BEAT's a really good source of information. I know we're thinking a little bit more about ADHD, but actually lots of kind of information on the National Autistic Society website. There's whole sections and pages on food and eating, and lots of those strategies that help children and young people who are autistic, who have difficulties with food and eating, can be useful for patients with ARFID, but also for those with ARFID and possibly kind of ADHD as well.
I think the message that I'm getting from you, there is support out there, and I think for us, for parents, certainly listen to this. Maybe struggling with a young person that might possibly have ARFID as well. The thing is to educate yourself, read more about it, and there's no harm, even if reaching out to the GP to get referral. It doesn't mean that everyone that comes through your clinic is going to get a diagnosis of ARFID. I'm sure there's other young people that you've seen that might not necessarily meet that diagnostic threshold, but I'm sure you still signpost them and offer them support or interventions, or point them in the right direction. But I'm hoping this, if we sit down in 5 years' time from now, you will probably have more information from us, particularly from a research point of view, and certainly with the link between ADHD and ARFID as well. There will be much more research done in that field. So it'd be interesting to see how this evolves, particularly over the next few years.
Yeah, I hope so. We should definitely do that. We should sit down in 5 years' time, see where the literature's at, see if we have better understanding, of ARFID generally, or just more literature on ARFID generally across different populations and, all sorts of different people and presentations, but especially, alongside neurodiversity as well. So I'd be keen to do that.
Yeah, and certainly the interesting thing for me is ARFID sitting or seen as an eating disorder. That's interesting in itself.
Yeah, and I think it's currently sitting there because to a large extent it's about the diet. It's kind of the food going in. It's a limited diet in terms of variety or volume. But whilst it's about kind of the food, also we do have to think about kind of broader things that are affecting the diet as well. So often there is a high prevalence of kind of neurodevelopmental conditions that maybe we should be thinking about as well, or mental health conditions. So if we're really anxious, that can affect our appetite. If we're really low in mood, that can affect our appetite and our eating as well. So it's currently positioned in eating disorders, or in the eating disorders kind of category within our diagnostic manuals. I imagine it will stay there, but I think there is kind of broader conversations about actually how does this fit with neurodevelopmental conditions and disorders and mental health conditions as well. So I think it'd be interesting to see where the field moves across the next 5-10 years. Yeah,
absolutely. Any final thoughts or messages that you'd like to share with our listeners at all, particularly around this fascinating area that we've been discussing on our ARFID?
I think I'll go back to that point about, I think as clinicians we can end up working in silos, just the way that services are structured. And so, if you're in an eating disorder service, be thinking about neurodiversity and possibly screening for that, and whether further assessments indicated and referrals need to be made for that. Equally, if you're working in neurodevelopmental services or general mental health services, perhaps we should be asking a little bit more about food and eating and diet and thinking about kind of the holistic needs, which I think sometimes we do, but sometimes I think if it's then flagging, it's like how do we probe a little bit further, and do we need to screen for ARFID, or is further support needed to check out kind of physical health or nutritional health? So sometimes it's not always saying that people need to see psychologists or go to a specific ARFID service. Sometimes it is kind of going to your GP and just having a check on kind of physical health, or thinking about referrals to dietitians, for example, who could think about nutritional adequacy and advising around kind of nutritional strategies to try and support a diet to be as good as possible within the really limited range. So I think I would just say, like, whilst, we might work in these kind of siloed ways and services, it's always thinking about like broadening the lens and broadening out that kind of picture.
I agree. I think working in silos, that's one thing that I wish, given that the NHS is a huge service, when you look at how, you have mental health services one end, you've got neurodevelopmental services, eating disorder services, but clearly, I agree with you. I think some integration needs to happen. And certainly things like podcasts, us talking about things like this, people going online, social media, it's all playing a part. And certainly, if it's sad to hear that it's taking the families themselves having to do their own research to actually then go, I think my son or my daughter might have ARFID, and then going to the GP. Certainly, this should be coming from us clinicians as well, educating ourselves. So
yeah, absolutely. And how can we as clinicians, I'm a clinician that works and specialises in ARFID, and that's why I'm keen to do things like podcasts, and I do quite a lot of like talks, and because I think it's how do we spread awareness of ARFID, and how do we get more people hearing about ARFID? Because I think that is a huge frustration when you go to the doctor and you're explaining things to the doctor and they say, oh, I've never heard of this before, but there it is. It is an absolute term. It sits in our manuals. And I think, the more that people hear about ARFID, that will just reduce a barrier to accessing kind of support and services, and even just to be met with, oh, I've heard of that. I kind of know, tell me more about that, rather than what is this and having to Google it. And I know GPs have to deal with a huge wide range of kind of conditions, but absolutely spreading awareness of ARFID is I think one of the goals that we should, that those of us that are working in ARFID should absolutely have and should be trying to do.
Amazing. So finally, what's next for you?
Oh, that's a very good question. I feel incredibly lucky to work in an area which I'm very, very passionate about, very interested in. No day is the same. So every day is a bit different. And, every patient with ARFID is a bit different, because I think some people say to me, oh, you've specialised very early on in your career. But, like I was saying, it's a very different presentation, and what you need to do needs to often be quite nuanced and individualized and based on our kind of psychological formulation of that particular individual and person. So I love, even though ARFID's a niche area and people might see it as a bit the kind of same every day, there's huge breadth within ARFID. So I think what's next for me, I'm working in London in the ARFID world. I've been lucky enough to work at some amazing hospitals and services, and I'm just continuing with developing my experience and working across different services, because different services and different people that you work with, different disciplines, think about ARFID differently. And what I am loving is not just supporting the patients and families, who are just always amazing, but working with really interesting people who, I love kind of debating about ARFID and think about like neurodiversity and ARFID and what do we do? How do we best manage? And so, currently I'm just kind of building my experience, going around different services, exploring how people think and manage and support patients with ARFID. I think what's next for me in terms of the research world is I would really like to kind of do more and more projects that focus on kind of ARFID and neurodiversity and the overlap there, possibly a little bit of kind of ARFID in adults as well, and think about that kind of experience. So definitely I hope that the kind of future for me involves a huge amount of kind of clinical work with this patient group that I really, really enjoy working with, and their parents, who are often just absolutely incredible and are trying really, really hard and are so creative and inventive and innovative. And I learn my best strategies of how to manage other ARFID patients from speaking to, other parents and things. Spreading awareness, lots of talks, podcasts, that kind of thing. I hope I carry on doing more of that and research as well. So there's never a dull day or a dull moment working in ARFID. I'm very, very pleased and privileged to work in this area.
Exciting.
It's really, really exciting, because it's so new and it's emerging. It's exciting to be part of that.
It is, and certainly I'll be interested to see how all this pans out, as I said, over the next years or so. But certainly for me, listening to you, I want to take the message from this to be much more aware of it. You've educated me today. I've done some research prior to us doing this podcast as well on this ARFID. So I would like to think every time, and that's a good thing with the podcast, you learn. As a clinician, you are, as much as I'm doing it for the listeners as well, but I'm doing it for myself and for our clinic as well. So if people want to reach out to you, find out more about yourself, how can they? My handle is,
I've got different handles across different social media platforms. So you can find me on Twitter. I have a professional presence on Twitter. So my handle is at mwills11. So that's EMWILLS 11. And I also have an Instagram account, a professional Instagram account, at Dr Emma Willmott. Willmott is spelled WILLMOTT.
Amazing. Excellent. It's great to catch up. It's been a while.
It has been a while.
Very.
We were saying, 3 years. So at the beginning of the pandemic, I think was the last time we met. Maybe it's been a little bit longer than 3 years.
A little bit longer than that, certainly from my memory. But certainly I think when we worked together, you were obviously still an assistant psychologist at that time. And so I've tracked your journey.
You have. You've been there right from the beginning, from assistant psychologist. I think you met me when I was newly qualified, and now I'm a senior clinical psychologist. And who knows, if we do that podcast in 5 years' time about kind of where ARFID and the ARFID field will be, who knows where I'll be, Archie? I don't know.
Honestly, like, you probably wouldn't recognise me. You'll be just walking past me like, who's that, Archie?
Well, we used to, I don't know if you even remember this, but we used to desk share, right? Do you remember that at CAMS? Because we used to work on kind of different days of the week. So you were just a theoretical, hypothetical kind of construct to me of someone who used to just sit at my desk. And I just heard of this Archie, and I was like, oh, you better not move my things. And then obviously, I think, I don't know, my working days changed or your working days changed, and obviously we overlapped, and I'm very glad we did.
And then, do you know what? I used to give you a lift to work. Do you remember?
Yeah, you probably did at times. Yeah, because one of the classic issues of working in the NHS is then there's never any parking spaces. So, it's good to car share where you can.
Car sharing, exactly. That was good memories back then. And and as I said, I'm glad to see how your career has progressed, and certainly I'll be interested to see how it's going to progress even further, particularly in this ARFID field and world, particularly the research. If you can if you need any support with any of data, volunteers and things like that, just reach out.
Oh, thank you very much. I know who to come to about anything ADHD related, which is fantastic.
Absolutely. Dr. Willmott, it's been an absolute honour having you. And as I said, we're going to put all your description links and everything in the podcast description. There's something else you mentioned as well that we wanted to add to the podcast, that I think the website link. Yeah,
I will send you links for kind of websites and perhaps some of the studies maybe that I've touched on today, like one of the ones about the kind of the stimulants, for example, for a population that have ARFID and ADHD, and also maybe the links to the websites, and there's some books and things that I'll send you the links for as well.
Brilliant, amazing. Thank you very much for coming, and go well. All the best.
You're very welcome. You too.
Take care.
Thanks.